All right, everyone. I have a few cases to discuss with you. The key point for this video is time. Okay? Like I've said before, time is the most valuable resource that we have as emergency room physicians. Time is the one resource that we most manage acutely, right? I cannot get more time from the pharmacy. I can't consult more time. I can't do a procedure for more time. Once time passes, it's gone. Okay? Time is the school in which we learn, and time is the fire in which we burn. That's a line from some famous poem by some dude. The only reason I know it is because it was a line out of Die Hard 3. All right, here we go. So here's the first case. Chest pain. This was my case. I had this over the weekend. Mid-sternal chest pain started around 9 a.m. Chest pain that started 2 hours ago describes it as a central pressure, like something is sitting on his chest. That's not good. Non-radiating, no diaphoresis, no shortness of breath. That's kind of reassuring. Previous smoker, no history of coronary disease. So this was a good dude, came in. His only risk factor was smoking. He had most of what he was describing was good. He's like, this is pressure in my chest. It feels like something sitting on my chest. And he kept doing that sign. I forget the name of it. What's when you have a fist over the center of your chest. I was definitely concerned. All right. Here we go. Here's the first EKG. Once again, I recommend you pause and go through it on your own and then see what I have to say. Again, here's the rhythm strip. I see a P, QRST. I see a P, QRST. So I see one P for every QRS. So we're sinus for the rate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. 15 times 6. 6 times 5 is 30. 6 plus 3, so 90. So we have a rate of 90. So we have a normal rate, okay? Normal sinus, okay? For the access, we're up in 1 and equivalent in AVF. I'm going to say it's more up than down. So, normal access to, slash borderline left, okay? For the intervals, I do not see any prolongation of the QTC. And for the QRS, I do think it's greater than 3 boxes. Down here in lead 3, we can see here's the beginning of the QRS. There's the end. Let's see, 1, 2, 2.5. I take it back. So we have normal QRS and a normal QTC. Okay, both normal. Now, let's get to the ST segments. And again, let's go through every lead. Up here in lead 1, there is my PR segment. There is my J point. I am seeing J point elevation in this lead. Okay. Here in lead 2, there is my PR segment. There is my J point. Again, I'm seeing PR elevation in this lead. Here in lead 3, there's my PR segment. There's my J point, PR segment, J point, maybe like 0.5 millimeter of depression in this lead. Up here in AVR, there's a lot of artifact, but I don't see any definitive J-point deviation. Maybe some J-point depression from the PR segment, but hard to tell with all the artifact. Over here in AVL, there's the beginning of my QRS. Where does it end? Tough to tell here. Remember, we can always extrapolate out. Okay, so down here in AVF, there's the beginning of the QRS. There's the end of it. There's the beginning. There's the end. So here's my J-point. Right here, it follows on this big line, so let's just follow it up. There's my J point right there. And I do have J point elevation from the PR segment, okay? Up here in V1, I do see some J point depression from the PR segment. In V2, I'm not seeing much J point deviation. In lead 3, I do see some J point depression from the PR segment. And again, this linearity of the ST segment, which is, concerning to me. Here in V4, I'm not seeing much J point deviation. Same thing in V5, not much, maybe 0.5 millimeter. Over here in V6, let's extrapolate out our QRS, right? So here's the beginning, here's the end. So here's my J point, which matches up with this small line just before the big line. So let's follow it down. There's my J point, there's my PR. Not much, maybe like 0.5 millimeter. Okay, so I do have J point deviation. In multiple leads, specifically elevation in some and depression in others. Okay, so my overall findings is A, normal rate, normal sinus, normal to borderline left axis deviation. Okay, I have a normal QRS duration and normal QTC. I do have J-point deviation in several leads, including elevation in some with depression in others. Now all of my findings accompanied with my pretest probability with a substernal pressure, for me this is concerning, and I called this an infarct. Okay? Now, so I called it a STEMI off the bat. The cardiologist calls me back, and they were like, well, why don't you repeat another EKG? And again, just so you remember, like this was at 10:52, and I had nothing old to compare it to. Here's the repeat EKG. The tracing is much better, but let's go through it again. Okay, here we go. I have 1P for every QRS, and the rate is normal. So I have normal rate, okay? Normal rhythm, okay? For the axis, in this one, I can see much better. It's more down than it is up in AVF, okay? So now I'm calling this left axis deviation, okay? For the intervals, once again, I don't see prolongation of the QRS and QTC, so the QRS and the QTC are both normal, okay, which is good. We'll put norms down there. All right, now for the ST segments, again, let's look through here. Okay, so the main issue for this case, and the interesting things, again, is lead 1 and AVL. Okay, we have this sloppiness here, like around where the J point is. Where does the QRS really end? Is there really J point deviation? Well, let's use our tricks. Okay, let's go through and look at other leads where we can determine where the QRS specifically ends. Okay, here looking at the lead 1, lead 2, and lead 3, it's tough to tell. Okay, but here in lead 2, I can clearly see the QRS begins there and the QRS ends there. Here's my J point right there. There's my J point, and it just corresponds with this small line before the big line. So when we map this up, boom, there is my J point, and again we see J-point deviation from the PR segment. Like, yes, there is this slop in here and this notching again, but the short of the story is once you extrapolate out where the J-point is, you do see J-point deviation. Again, here in lead 2, I do see 1 millimeter of J-point deviation. And again, mapping out our isoelectric point, our J-point, there is my J-point, there is my PR segment, and I see J-point depression here. Okay. Now I get a better picture up here in AVR. There's the beginning of my QRS. There's the end. I do have some J-point deviation downwards. Same issues here. Here's our J-point just after this small line. Again, there's our J-point right there. Here's our PR segment and J-point, and I have ST elevation here. Here in lead 3, I'm not seeing much J-point deviation. Up here in V1, as we saw before, there is some J-point depression. And also note the linearity, straightening, and downward deflection of this ST segment. And again, this amount of linearity here in this ST segment is definitely over half the amplitude of the QRS. I mean, that's concerning for me in any patient who has a high pretest probability for coronary artery disease. I'm not seeing much J-point deviation over here in V2. Again, in V3, I'm seeing some J-point depression of maybe 1 millimeter in these leads. In V4, maybe a quarter millimeter of depression, but nothing significant. Not much in V5 and not much in V6. So again, as similar, I have J-point elevation in some leads and J-point deviation in some leads with a repolarization abnormality. Okay, so this is my overall findings, right? Normal rate, normal rhythm, left axis deviation, the QRS duration and QTC is normal. I have J-point elevation with J-point depression in other leads and focal repolarization abnormalities, right? Like even if I couldn't see this EKG, if you told me that over the phone with a history, I would be like, shoot, this is an infarct, send to the cath lab. So back to my case, the cardiologist is like, well, the repeat without the artifact looks better to me. I don't think we need an emergent catheterization, okay? So here's what happened. Okay, first troponin was 34. Okay, next one, 496, 8 Gs, 18 Gs, 17 Gs, 17 Gs. Okay, so, all right, and here's the cath 2 days later, okay? 2 days later, greater than 48 hours. It was like 52 hours maybe. We do have some disease, okay? This is the RCA, okay? And you can see there is some disease, right? Like we have some narrowing here, we have some narrowing here, and we have some kind of poor flow down here. Now, there's no like 100% occlusion or anything, but again, this person has disease, right, which is concerning. Here's a bunch of pictures of this LAD where there was lots of disease, okay? Again, I'm not a cardiologist, and this picture I'm just, taking copies off the computer. I mean, there is some disease and problems with flow here. Look at this narrowing here, right? There's narrowing here as well, disease throughout. Here's a better picture of the LAD where we can see all this disease and the report as well. I mean, look at all this disease up here. Like, look at this up here, like disease, like look at this stenosis, just overall looks crappy. Look at this down here, like look at this lack of flow down here and here as well, like diffuse disease. Okay, and here's what the cath report said. Left main is normal, LAD diffuse mid-LAD stenosis raising from 70 to 80%. RFR significant, that they're measuring the refractory flow, so it's a significant stenosis. Multiple lesions noted on ultrasound, severe proximal mid first diagonal branch stenosis up to 90% with plaque ulceration visualized. This was likely the culprit for the lateral stegment elevations initially noted on ECG. Circumflex 60% with OM1 stenosis, right coronary non-dominant 50 mid stenosis. Ejection fraction around 45%, that's not good. And global hypokinesis, that's not good as well, okay? So they put some stents in and stuff like that, and here we have his echo, okay? Oops, sorry. Increased wall thickness, okay? Ejection fraction, 35%. C wall score motion for wall motion abnormalities. Like, this is what we not want. This is what we do not want, okay? Too much time went by. Now his heart muscle is dead. Now he has a low ejection fraction. Now he has focal wall motion abnormalities. Now he's at risk for ventricular tachycardia. He's going to be on diuretics and beta blockers that make him dizzy and fall and blood thinners, and he's going to fall and cut his scalp and come to the emergency room over and over again because it won't stop bleeding. Like, all of this could have been avoided with time, right? If we would have cathed them right away, we could have avoided this. Now the time has passed. We've lost all benefit. Now, you guys are all residents and or med students. Okay, so this is a delicate topic to broach, like, well, what do you do and how do you practice? Again, at the beginning of all of this, I told you in all these videos, I'm just going to tell you how I practice and why I do it. I'm not saying that's the way you should do it or that's the way it should be done. Okay, for me, for these cases, depending on where I'm at and depending on many factors, if I feel strongly enough, I'm going to call it a STEMI. Okay, this was a Saturday, right? And we have this giant storm coming up. I didn't want to wait on this guy. I knew if we didn't cath him right away, it would be delayed because of the storm and what's going on. We lose all benefit, and that's what happened. And again, ER doctors are the lowest people on the totem poles. You can't really bully or force or yell at your colleagues on the phone because that's not going to go anywhere. So what I do is I do what I think is best for the patient, and I objectively chart what happened. Okay, so here's what I charted. My exam, the patient looks pretty good, but he's non-toxic, well-appearing, no acute stress, Lernoid times 3. The EKG indicative of acute infarct with ST elevation and 1 AVL and reciprocal changes. I'm going to activate the cath lab, give him aspirin and heparin, okay? Spoke with Dr. Blank, the cardiologist, who agrees with the plan of care but requests repeat EKG, okay? I reviewed the repeat EKG with the cardiologist, who was no longer concerned for acute occlusion that warrants emergent intervention. The patient will be placed on heparin and nitro and admitted at the end of the day. And again, before he went upstairs, I reevaluated him. Upon reevaluation, the patient is resting comfortably and reports pain-free on nitro drip. Everything I say in here is fact. Like, I'm not accusing anybody of anything. I'm just describing what I did and why, okay? Again, that's the way I approach it, and that's the way I do it. I'm not saying that's the way you should do it, but it's different. I mean, because most of you guys are at Toledo. At Toledo, we have cardiology in-house. They can just come down and check the guy and talk to him. But like at other hospitals, when we don't have that, I mean, we have to be like a component for the patient. We have to do what we think is best for them. Okay, and it's a delicate line you have to walk in order, I mean, doing what's best for the patient, but not angering everyone in the hospital and getting in trouble. But at the end of the day, just do what you think is best for the patient. Here's what the literature shows. Lateral wall myocardial infarction, ECG findings. And that's the other thing is, you know, this EKG 1 in AVL is consistent with like a high lateral infarction, which is most likely from the circumflex. Most of the time in the literature, like those type of infarctions don't do as poorly because normally the circumflex doesn't have a large area that it distributes. And again, for me, like in your test questions on your boards, they're going to ask you, well, which vessel this is. You know, is it left, right, you know, RCA, circumflex, LAD? For me, I don't care, okay? Because, like, number one, it depends on your heart anatomy, whether you're left heart or right heart dominant. And I don't care what vessel it is. The main thing is we're identifying there's a vessel that has an acute occlusion that needs to be fixed promptly. Okay, we need to conserve time. Okay, so here's the literature. Lateral wall MI, ST segment elevation in leads 1, AVL, V5, and Z6 with reciprocal changes. Most times I call that the South African flag sign, which we talked about before. High lateral presents with ST segment elevation, 1 AVL, several ST segments in V5 and V6 with reciprocal changes, often caused by occlusion of the first diagonal branch of the LAD, sometimes for the South African flag sign. There you go. Old LMI, deep, broad Q waves in leads 1 in AVL, inferior lateral STEMI, ST7 elevation 1, AVL, V5, V6, anterior lateral segment, ST7 1, AVL, V5, V6, etc., etc. So the shorter story is 1 in AVL elevation, normally referred to as a high lateral. The literature sometimes says that it's not as bad because it has a small area of infarct. For me, I don't care. What I care about is we're identifying a vessel that's occluded that needs to go to the cath lab. Here's more information about high lateral infarcts, which you all can read because you're literate, and the website is down below, which you can peruse at your leisure. Okay. Next case comes from Dr. Kira Porter. She was one of the Monroe residents who graduated a couple of years ago. She sent me this case recently via text. Same thing, I look up her name. Porter is an English and Scottish occupation name originating from the Middle English Old French portière or porteur, meaning doorkeeper, gatekeeper, or carrier of goods. It was given to individuals who controlled access to castles, monasteries, or walled towns, or to those who transported goods reflecting roles or responsibility of service. Every time I look up these names, I'm surprised at how more and more apt they are. Like, Porter definitely is a gatekeeper. Okay, like, I can totally see her in the medieval times, like, at the gate being like, hey, who are you? Where are you going? What are you doing? What's up with that sword? Where'd that come from? And same thing with patients. Like, I mean, she's a great doctor, good to her patients, but, if her patients try to pull some stuff, she's like Gandalf when he's on that bridge and he's like, you shall not pass. Like, that's Porter to a T. All right, so here's the text. Whoops, I got these out of order. Okay, my bad. So this was the first text I got. Actually saved a life. 25-year-old male, 5 to 6 days preceding flu-like illness, had 1 hour of sudden onset, nausea, vomiting, shortness of breath, and retrosternal chest pain that's vague, achy, and not reproducible or positional. Non-radiating, woke him up from his sleep. Remember the 3 a.m. witching hour when we all died because our platelets are more sticky. He's tacky and tachypnic, but satting fine, not hypertensive, looks ill and uncomfortable. No known ACS risk factors, no medical history, but not the healthiest guy at baseline. How would you play this? STEMI alert, CODS consult ASAP, or work them up then consult. Here's the EKG that she sent me, and once again, I recommend you go through it, but here's what I see. Okay, here's lead 2 for our rhythm strip. I see 1P before every QRS. We're sinus. Let's see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17. So we got normal sinus, and we got 17 times 6. I'm not a calculator, but it's borderline fast. Okay, so fast. For the access, we're up in 1 and up in AVL, so normal access. Okay. For the intervals, I'm not seeing, well, maybe there's borderline QT prolongation. I refer to the machine, but I don't see any widening of the QRS as it's not over 3 boxes. It's close, maybe 2.5. So normal QRS and normal QTC with a caveat that I would defer to the machine for that. Okay. Now for ST segments, let's go through it. Up here in lead 1, there's my PR segment. There's my J point. I'm not seeing much deviation. There's my PR segment. There's that J point, maybe 0.5 millimeter. It's tough to see with all this artifact, but again, this linearity of the ST segment here is concerning to me, especially since it's over half the amplitude of the QRS. Same issues down here in lead 3. I'm not seeing much J-point deviation, but again, note the linearity and negative deflection of these ST segments. And also note that the linearity is greater than half the M2 of the QRS. Up here in AVR, again, tough with the readings, but I'm not seeing much J-point deviation. But this morphology of this ST segment is kind of concerning to me. I mean, it looks like it's straight and upward, but again, difficult to tell. Here in AVL, I'm not seeing much J-point deviation, but I am noting this linearity and slight downward deflection of the ST segment, which is concerning. Up here in AVF, again, I'm not seeing much J-point deviation, but this Downward deflection is concerning to me, and linearity as well. Up here in V1, I mean, we have obvious J-point elevation, right? Like, look at that. That's like 1, 2, 2.5, almost 3 boxes. Tough to tell. And same thing down here in V3. There's my PR segment. There's my J-point, like 2 to 2.5 boxes of elevation. Same thing here in V3. There's my PR segment. There's my J-point. Over here in V4, I'm also noting J-point elevation here of approximately 1 millimeter. I'm not seeing much in V5. In V6, I'm not seeing much J-point deviation, but I do see this linearity, downward deflection, and straightening greater than half lamb to the QRS. So I do have J-point deviation upwards in certain leads, as well as a focal repolarization abnormality. Okay, so my overall findings: normal sinus, borderline tachy, but would defer to the machine. Normal access. I mean, for me, the QRS is not wide. The QTC is not wide, again, with the caveat referring to the machine. I do have J-point elevation in certain leads and focal repolarization abnormalities, okay? So for me, this is highly concerning for an infarct, okay? So here's what happened. Ended up being 100% LED stenosed. Dr. Porter called GenCards ASAP and asked if they wanted me to get an angio first or go ahead and activate. The cardiologist talked to the interventionist directly, who decided to activate and took them back ASAP. Think that's the youngest STEMI I've ever seen so far, but thanks for your input. I didn't really give her real-time input. Like, she texted me, and I texted her back like 2 days ago because I'm a moron. But what Dr. Porter did was exceptional. Okay, number one, didn't throw away the fact that he was only 25. With these EKG changes, she was concerned for an infarct, but she was also concerned for a PE and dissection, correct? Like, we've seen other cases where, a PE can cause elevation in the precordial leads. So what she did is the ideal thing. She coordinated with her specialist in a timely manner to conserve time. She talked to the cardiologist, and she's like, hey, here's this guy's story. Here's his EKG. I know he's young. I'm worried about an infarct. What do you think? Do you think it's appropriate to cath him right away, or do you think I should CT scan for the pathology? They took him back to the cath lab, and he had a great outcome, okay? Now, the question is was this a STEMI? And the answer, in my opinion, is, well, not really. It's tough to tell. Okay, remember, if the question is what is a STEMI, this is the most current rules of what a STEMI is, in America at least. Okay, and here's the ST elevation that you have to have in order to be a STEMI. Okay, new or presumed to ST elevation of greater than 1 millimeter in 2 or more anatomically contiguous leads, measured at the J point, okay, in all the leads. Other than V2 and V3, so you have to have more than 2 in men over 40 in V2 and V3, more than 2.5 in men under 40, which I don't think this guy qualified for. I mean, he had 2.5 in V1, V2 was maybe like 2, V3, like he didn't really qualify. And 1.5 millimeters in woman, regardless of age, in V2 and V3. Okay, so that's the thing is, STEMI is all relative. Like, it's a relative term. It depends on who you're asking, and also depends on what country you're in. Like, what governing body are you, like, referring to? And I've said this before. Like, STEMI is a relevant term, in my opinion. Like, it should be symptoms, risk factors, and focal repolarization abnormalities that should be driving our decision. And this highlights why, right? It's like time. Like, if you just stick to these straight rules, you're going to miss cases, you're going to lose time, and patients are going to have bad outcomes, like you saw in my first case. Okay, and again, what does the literature say? Okay, for any thromboembolic pathology, whether it's a STEMI, whether it's a stroke, ischemic limb, a PE, anything where there's a clot that affects blood supply, time is the most important thing. Right, here we go. I mean, there's many like articles you can find. Here's just a couple. This study confirms previous work that time to treatment for STEMI is a crucial factor in reducing deaths and disability in patients with acute coronary syndrome. Okay, here's another one. This study, they found participants with longer time delay, over 48 hours, had worse 3-year survival. Like my dude, it was longer than 48 hours. And remember that one study we talked about out of, I believe it was Korea? That was the thing. They measured time from onset of symptoms to cath, and their Rubicon was 48 hours. Like, before 48 hours, there was some benefit. After that, you lost all of them. But again, that was just one study out of Korea. Again, here we go with PE, right? Early CBT was associated with improved clinical outcomes in patients with acute intermediate risk PE. Same thing, more evidence of PE. Patients who underwent CTD within 24 hours of admission were more likely to have shorter hospital stays and ICU length of stays, okay? Here we go for stroke. I mean, we all know about stroke. It's out there, okay? Every hour increase from stroke onset to EVT starts resulted in a 5.3 decrease probability of a functional independent modified Rankin score of 0 to 2. Time. Time is the school in which we learn. Time is the fire in which we burn. Faster time to treatment with ETV for acute stroke was associated with greater home time, particularly within 4 hours of onset to puncture and 2 hours door to puncture time. Within 6 hours of stroke onset, each 13 minutes of faster treatment is associated with a gain of 1 day home time. Time. Even with peripheral vascular disease, right? I mean, this one, a delay of 30 days from CTLI diagnosis of lower extremity endovascular canalization was associated with an increased risk of major lower extremity amputation among patients undergoing outpatient endovascular revascularization. Time. Same thing with arterial injuries in the extremity within 1 hour of injury. Time. Okay? So anytime there's a thromboembolic problem, whether it's stroke, MI, PE, ischemic limb, ischemic gut, any of that stuff, time is the most important thing. Like, this is when we should pull the trigger, be our doctors, be aggressive, and get stuff done, okay? And again, there's a modified Rankin score, but I have, my outcomes as far as it comes to thromboembolic events, and I have 8 of them. Number 1 is what we strive for, okay? Number 1 is what Dr. Porter did. I am fine. I am normal. I have no issues. I came in with this weird EKG, and even though I was 25, Dr. Porter got me to the cath lab within an hour, and I have no issues. That's outcome 1. Outcome 2 is my case. Hey, I had this EKG, I came in, but my cath was delayed. Now I have issues. What we're striving for is level 1. Okay, level 2 is also appropriate. You have some issues, but you're fine. I mean, you can do all the stuff you did before. Like, hey, I had this stroke, and it made my left pinky numb, but I can still do everything I want to do. Like, I can still go to work. I can still do my woodworking I like for hobbies. Like, yeah, I have some symptoms, but it doesn't change my life at all. Level 3 is where I start. It's like the silver level. Like, you're fine, but you have to give something up, right? Like, I had this stroke, and my right pinky is numb. I mean, I can still go to work. I can still feed myself and stuff, but I had to give up woodworking because I couldn't, do my fine motor movements anymore. And yeah, it sucks, but you still have, a good life, right? The next one is you need something, but you don't depend on it. The classic person I think about is the old person who likes a walker. I mean, they use a walker to get around, but it's not necessary, okay? The next one is you're a cyborg. You depend on something, like a cane or a fake leg. I had polio as a kid, and I can still get around, but I need this cane and this brace or else I'll fall down, okay? You're still independent. Number 6, you depend on someone, but you're still relatively independent. The classic is assisted living. Yeah, I had a stroke and I'm old. I can't live by myself anymore. But as long as I'm in a facility where there's people who can tell me, when to eat and to pay my bills and stuff like that, I'm fine. I still have some independence. 7 is, you're no longer dependent at all. You depend on people for everything. This is the demented patient who can no longer feed themselves, go to the bathroom, take their meds. That's someone who depends on everything for someone for everything else. And level 8 is you depend on machines, right? I had this MI and I lived, but I have significant brain damage and now I have a GCS of 4 and I have to be on a vent and dialysis and tubes feeding me or else I'll die. I strive, for 1 and 2. 1 and 2 is gold, 3 is silver, 4 and 5 is bronze. 6, 7, 8, that's when you're giving up your independence. For me, that's one of the worst things. Treat your patients like you want to be treated. For me, losing my independence would suck. I would rather die than lose my independence. So that's what I got for this video. Short of the story is time is important, and we must be aggressive when time is a critical factor. That's all I got. Hope you enjoyed. Any questions, ask me in person. Patrick is done.